And it is now my honor to be able to bring up our next panel. This panel is going to describe the statewide efforts of state and counties to address the issue of psychotropic medication in foster care, both in terms of compiling the available data to better understand the problem, and also in terms of creating systems of care that better protect kids. For each panelist, as a request, as you talk about the activities you're working on, I know that Senator Hancock and myself would like you to also comment on how these efforts are working to be able to protect youth across the state. Just a few items. I also want to say a hearty thank you to Karen Dessa from the Bay Area News Group, who is also here today for her amazing work. And I just wanted to call her out and tell her how much we appreciate her continuing coverage on this important issue. And then the other item is we're grateful that Director Lightbourne, among our other panelists, are here today. And I just want to note that Director Lightbourne came to the state in 2011. And Director Lightbourne, in a separate conversation that I had with him, is committed to be able to not only tackle this issue, but the continuum of care. And his report was recently released, and I know that we're going to be working with him throughout the year. I'd like to be able to introduce our panel here very quickly, and then, of course, turn it over to Will Lightbourne, who is the Director of Department of Social Services. We're grateful that Dr. Karen Baylor is here. She's Deputy Director of Mental Health and Substance Abuse Services with the Department of Healthcare Services. We're grateful that Diana Cocos Gonzalez is here. She's Chief Mental Health Services Division, Department of Healthcare Services. Frank Meka is here today, who's the Executive Director of the County Welfare Directors Association. Thank you so much. Along with Dr. Bill Arroyo, who is Medical Director from Los Angeles County, and he's going to be speaking on behalf of the County Behavioral Health Directors Association. On behalf of our committee, we're grateful that you would take time out of your busy schedules, and let's kick off our state and local oversight and response panel with Director Lightbourne, and you have 4 minutes, sir, and we'll have questions at the end.
Thank you, Chair McGuire, Senator Hancock, and Pete Chervinka from our department, he's the Program Services Deputy, is passing out a slide deck that I'll refer to in a few moments. It's a report that we prepare for the Child Welfare Council, which is where we've been updating this issue on a regular basis. There was an op-ed in last Saturday's Mercury, which I think is very apt, and it sort of outlines the issue in front of us. A child's severe and sometimes delayed behavioral response to maltreatment requires more individualized assessment and treatment in the context of family and community care. There are some children who are and should be appropriately treated with drugs, but we should be thoughtfully determining which ones those should be, under what controlled circumstances, and not medicating girls and boys for behavioral controls. In the slide deck that we presented, the first slide, simply for your reference, is a description of the primary drugs we're talking about, the psychotropics. On slide number 2, I want to focus on this for a moment, because although we're facing really very significant challenges, I also want to strike a note of optimism, because we're at a point where initiatives are aligning and are supporting where we're trying to get to. The work in this area is multifaceted. Considering the appropriate treatments is not done in isolation, but it's done in the context of social work practice and inclusive planning. To that end, as described in the very good staff report, for which we're grateful, California is now implementing a core practice model for child welfare. This calls for robust, trauma-informed, accurate assessment of a child's needs and strengths, an assessment that's informed by the participation of the child, the family, relevant professionals, and caregivers. These assessments by child and family teams are the starting place for the continuum of care reform, which, as the chair mentioned, was released with the governor's budget on January 9th, and is the administration's proposal for restructuring the system of care. way in which we're going to address this issue is not by creating checklists or boxes. It's going to be by fundamentally restructuring the way child welfare is practiced and where children are cared for. The goal, of course, is to have children only in congregate care for treatment purposes in short-term residential treatment centers, time limited, specific case plans designed to step them down with services following them to caregivers in the community, preferably relatives or foster parents, who then receive the services that they need to meet the needs of the child in a setting where all of those qualities that Ms. Gonzalez and Ms. Hoffman were describing on the earlier panel. This is now largely possible because of the key components that are being implemented across the state at this point through the home and community-based services aspects of what's referred to as the KDA court suit settlement. And these strategies then in turn, using what we think of as wraparound services, but on a broader scale, intensive care coordination, and then therapeutic foster care, which we expect to be launched very shortly. These then will sit on the specific initiatives of the Quality Improvement Project, which was mentioned before. The Quality Improvement Project being the specific effort to address issues of medication and the utilization of alternative services. If we turn to slide 3, clearly there are a lot of parties who share in a process that we need to strengthen. We have caregivers, social workers, teachers who observe apparent needs of children. They in turn refer them to professionals. The professionals are assessing and to some extent diagnosing. The goal at that stage is to emphasize non-medical treatments wherever possible. Thereafter, if medication is required, the roles then of the court, of the children's attorneys, and of second opinions become crucial. Ultimately, what must be done is monitoring very, very closely and very, very carefully the effects of any medication that is provided. As Ms. Rodriguez mentioned, clearly there is a huge overlap between issues of group congregate shift care and the prescription of medication, and a major part of the continuum of care reform is evaluation of those short-term treatment resource centers that continue into the future, and the foster family agencies and treatment agencies that are providing services across the system of care. The goals of the Quality Improvement Project are described on slides 6 and 7. Fundamentally, to decrease the use of psychotropics, increase the use of psychosocial supports, and assure that the child's safety is always at the front of that. The deliverables of the Quality Improvement Project are the following: a foster youth mental health bill of rights, which is final now and is being distributed; questions that youth should ask of doctors, social workers, and judges to become more informed and active participants, that is complete; prescribing guidelines for doctors, which we expect to be finalized in March; prescribing guidelines and authorization guidelines for judges, which has been referred to the Judicial Council's March meeting; and the development of data agreements and report formats for monitoring and oversight between state agencies and county child welfare agencies, which are in finalization of exact dimensions regarding data safeguarding, et cetera. Our final slide really speaks to our vision. It's what we want to achieve, which is only having medications used when all other systems have been used, or a very strong assessment diagnosis indicates it. How we are working to get there through the continuum of care, the KDA implementation, and the Quality Improvement Project, and how we will know when we get there, how we've been successful. It will be a long road. The continuum of care reform itself, we expect to be a multi-year implementation. We can't simply wish away or close abruptly the congregate care resources until the family-based care resources and the foster family home resources are created, strengthened, and as Ms. Rodriguez indicated, in the context of the parenting initiative that we co-sponsor with CWDA and Youth Law Center, we have strengthened that sort of fabric of foster family caregivers as well as relative caregivers. And finally, data, training. Thank you.
Mr. Lightbourne, thank you so much. As I stated, what we'll do is wait for questions if that works towards the end of the panel. Let's turn it over to Ms. Baylor. She's Deputy Director of the Mental Health and Substance Abuse Services with the Department of Healthcare Services. Ms. Baylor, welcome.
Thank you. Thank you, Chairman McGuire and Senator Hancock, for this opportunity. We also share your concerns regarding this vulnerable population, and we have been working on a number of fronts, which I'm going to talk about. First of all, we're working on the data and working with interested stakeholders, and I know that can be frustrating at times, but I'm going to talk about that here in a minute. We are working closely with DSS, CWDA, and CBHDA more than we ever have before. We're working with counties, the providers, and pharmacists to make sure that they know the clinical and programmatic requirements. And then we also are supporting a number of different reforms in the foster youth delivery system. But let's jump in and talk about the data. We are governed, DHCS is governed by HIPAA. We are a covered entity, and that puts restrictions and certain requirements on the data that we can release for reporting to the public. We are responsible for making sure that these requirements are met for any data sharing for confidential data and to make sure that the data is de-identified. Not all of the programs that are under the California Health and Human Services are HIPAA-required entities, but we are. And so in order to maintain a balance between trying to be transparent and providing data, but at the same time trying to protect the information, we did develop a set of guidelines, which is the public aggregate reporting for DHCS business reports, and I believe that was mentioned in your background information as well. These guidelines were developed in 2014, and they have been in place since August of 2014, and all of the requests that we receive for data have to go through this guideline process. And then we also have to make sure that the data we release is not combined with other public data in order to identify who these people are. And so we're very protective of that. We do receive a lot of requests for data. We have a very large data system with lots of different data components, but and people try to reconcile data reports, but you have to keep in mind that there's parameters around each of the requests, and they're not the same parameters. So, for example, someone may ask us for data for foster youth, but they define foster youth as age up to 21. Others are wanting to look at foster youth just to age 18. Some want managed care plans included in the data, some don't. And so you get a variety of parameters regarding the data that we pull, and so that's why you cannot reconcile one report to another. We did recently implement a revised TAR process in October of 2014, and the TAR is the Treatment Authorization Request, and that is for any antipsychotic for 0 to 17 have to go through the TAR process. We've also done a frequently asked questions document that is a living and breathing document that is posted to the website, and so we update it when any more changes or questions come our way. We are willing to provide information and to make sure that we meet the requests that you have for your policy objectives. We have been meeting with the National Center for Youth Law monthly since October in order to refine their requests and get the data that they're requesting, and I know it takes time, but these are large data systems, and it does take time to really get the queries exactly to where you want them so that it answers the question that you want. And sometimes we ask very, very broad questions, and that needs to be refined in order to match up with what data we have available and to give you the answer that you're looking for. Some of the other efforts that we've done is as Will mentioned, we are working on the interagency agreement so that it covers all data necessary for the foster care children, and then we're working closely with counties to make sure that that is included in this interagency agreement. EPSDT, Specialty Mental Health Services, as you know, is an entitlement program. It is administered locally by the counties, but it is the responsibility of the Department of Health Care Services to oversee the program. We have sent out numerous information notices and all plan letters to the counties, to the managed care plans, to make sure that they know their responsibility in providing specialty mental health services. Director Lightbourne also mentioned the quality improvement project that we've been working on together and in developing guidelines. These guidelines are in final review, but they are posted on our website in draft form to give social workers and providers and judges and caregivers more specific information regarding the use of psychotropic medications. We're also willing to work with the Judicial Council in providing training and education because that's where the JV 220s go, and that's the last sign-off for authorization to administer the medications. We are supporting of many of the reforms that are happening. We're very supportive with DSS in moving toward a continuum of care reform. We've worked very hard together on the implementation of the KDA, and with that, I'm going to turn it over to Dina Cocos-Gonzalez to give an update on our KDA efforts.
Thank you so much. Good afternoon and welcome.
Good afternoon, Chairperson McGuire and Committee Member Hancock. The activities and services implemented as a result of the KDA settlement agreement are intended to transform the way California children and youth who are in foster care or who are at imminent risk of foster care placement receive access to mental health services consistent with a core practice model that Director Lightbourne spoke to earlier that creates a coherent and all-inclusive approach to the service, planning, and delivery. Implementation efforts for KDA activities are ongoing. As of January, 53 counties are providing intensive care coordination and intensive home-based services. There has been close and improved collaboration between the child welfare systems and the mental health systems, both at the state level between the Department of Social Services and the Department of Health Care Services, and then also at the county level between child welfare agencies and the county mental health plans, as well as with the associations, the county associations, and with the state departments. We are implementing a shared management structure to develop shared vision, policy and program direction, clear and consistent guidance and outcomes, and accountability measures. Part of that includes establishing formally an executive team, which we had our first meeting in January, and also establishing a community team. There is intense county outreach where the state departments together discuss implementation efforts with the counties, monitor progress, and provide technical assistance. KDA, the implementation activities and the results of that settlement have really put a solid foundation and structure in place for the systems that serve children and youth in foster care that can just be built upon for the other initiatives as we work on issues related to foster care.
And the senator is going to she has another committee meeting. She's going to be coming back. And Mr. Bell, we just got a note, is coming back here very shortly. And Mr. Monning is another committee meeting coming back here shortly. And I know it's a busy day, so thank you, Ms. Hancock. Now we're going to be, good afternoon, sir, and welcome. Frank is the executive director of the County Welfare Directors Association, and we're grateful that you're there.
I think,
Frank, yes. Go ahead, Frank.
all right, thank you. Thank you, Mr. Chair. Frank Micco at the County Welfare Directors Association. We appreciate your concern and the concern, obviously, of the other senators on the panel for this really important issue. I'm here to tell you that the County Human Services Directors find this to be an extremely important issue as well. We welcome your attention and interest and look forward to working with you. Certainly, the data is limited, but what's out there and our own experience tells us that it certainly appears that there is an over-reliance problem on psychotropic medications. And as everyone has said, for some youth, for some period of time, there is a place for this medication. It's our collective job, though, to ensure that psychotropic medication is not used as an alternative or in lieu of more appropriate and more efficacious non-pharmacological alternatives. The role of the County Welfare Department or the County Human Service Agency literally is that of the parents. When we remove a child from the custody, we assume a parental responsibility, and we believe we have the highest responsibility to ensure the well-being of those children. Our job certainly is not to be a medical clinician. We're not doctors. We're not psychiatrists. And we're not the final decision maker on whether a child may receive or may be prescribed an antipsychotic or psychotropic medication. Obviously, in our state, that decision is rested with the juvenile court judge. But our job is to be informed, to ask questions, to be an advocate for the children who are in our care, to work with our partner agencies to ensure an appropriate array of services for children within our care, to monitor their well-being, and to raise concerns if we have worries about whether or not the care plan is meeting the child's needs. The same things that you would do for your children, the same things that any of us would do for our children. Our association has participated in all of the efforts that we've discussed so far. QIP, the KDA process, the Continuum of Care Reform process. And there has been some excellent dialogue and collaboration with the departments that are here to be commended for it. And certainly our participation in all those efforts tell us we can do better as a state. And two areas that CWDA will be focusing on this year I'd like to talk about for a bit. The first area is to improve the court approval process. And the second area is to increase the supply of foster families and relative caregivers so children have alternatives to group care. With respect to the court approval process, a couple of the things that we need as social workers and the de facto parents, we need better information on what drugs kids are actually taking. In the JV 220 process, we know what pharmaceuticals have been prescribed. We don't know which pharmaceuticals have been picked up at the pharmacy, have been paid for. We don't know which pills have been swallowed necessarily. And so in order to properly monitor, we need better information about by child about exactly what drugs not just are being prescribed, but are being filled and are actually being taken. Because we're not experts, we need an alert system. We need some of the professionals, like the doctor that was on the first panel, to come together and give us an alert system so that when we find information that a child has been prescribed a particular drug at a particular dosage, if that drug is in a combination with another drug that might be dangerous, an unusually high dosage, contraindicated perhaps for a child of that age, we need to be alerted so that we can look out for whatever side effects or other consequences might come from that particular instance. We need more information in that court process, in that court approval process, about the totality of the child's mental health treatment plan. Not just the current one, but prior ones to the extent that there are, so that when a judge is given the information and makes a decision to approve or to deny, it's not just these are the behaviors Zoloft has been prescribed, but what do we know about the treatment that, if any, that the child has had up to this point? What else is happening in the child's treatment plan? A much more robust, full picture of the child's life, we believe, would improve the court approval process. We need a more systematic way to integrate the observations of caregivers and to give a voice for the youth themselves in that court approval process. And finally, in this regard, we believe many actors in the system need training: social workers, judges, CASAs, attorneys, so that we are knowledgeable and can perform our parental duty as effectively as possible.
No, thank you so much, and greatly appreciate your words. Good to see you again, sir.
Thank you.
And I know there will be some questions and comments. It's now my pleasure to be able to introduce Dr. Bill Arroyo, who's the medical director from Los Angeles County, and speaking on behalf of the County Behavioral Health Directors Association. Doctor, we're grateful that you would travel here today for this important hearing, and welcome, sir.
Thank you very much, Chairman Senator McGuire and Senator Bell and others who are here today. First, if I may make a minor correction to the agenda, my name is William Arroyo, so people call me Bill, but in the agenda it's William, just for the record. Thank you for that. So I am here representing the County Behavioral Health Directors Association, which, as some of you may know, is a policy voice of the 58 county behavioral health departments. I am a child and adolescent psychiatrist by profession, and I'd like to clarify something. I think there was some information shared by an earlier panel which warrants some correction, and that is that every child and adolescent psychiatrist is a physician by training. Every child and adolescent psychiatrist has completed medical school training. And so it is with that medical school background that we approach the treatment of children and youth who are on psychotropic medication. I am employed by Los Angeles County Department of Mental Health, where I serve as not the medical director, but I am one of the regional medical directors of the Department of Mental Health, and I also serve as the medical director for Children's Mental Health Services of the county, of the county's Department of Mental Health. I also am a treating child and adolescent psychiatrist for both dependents and wards of the state. During the past 3 years, I've had the privilege of working with staff from DHCS and DSS to address the twofold federal mandate of improving oversight of the use of psychotropic medication and addressing trauma in the foster care population. Currently, I serve on the state's clinical work group and expert panel, and was a member of the state delegation that went to Washington, D.C. in 2012 to get some preliminary technical assistance on these issues. The members of the association deeply acknowledge the vulnerabilities of children in the foster care system and are committed to assuring that their medically necessary mental health needs are met to support their resilience and healthy development. A wide array of services are provided to this population in many different types of settings, including the child's home. Some of these interventions have directly to do with helping those symptoms related to trauma, among other psychosocial interventions. Best practices require that psychosocial interventions are considered prior to the use of psychotropic agents. In regard to the oversight of the use of such agents, the county behavioral health departments employ child and adolescent psychiatrists to assist juvenile courts with the JV 220 review process. And as I think most of you know by now, that is the psychotropic administration request that is submitted to judges. So there is often communication between the county behavioral health department psychiatrist and the prescriber when there's a concern regarding a proposed medication regimen. After the review of the JB 220, the county psychiatrist will make a recommendation to the juvenile court judge for his or her decision to approve or not. Now, the review process varies from county to county depending on how many requests are made to the court. Last year, the state sponsored a statewide summit whereby counties shared their procedures in an effort to enhance their review process in their respective counties. Although not required by regulation, many counties use the same review process with their probation youth to, again, assure the safe and effective use of psychotropic agents in that population. Medications which are administered by physicians who work for managed healthcare plans are not the purview of the county behavioral health departments, and so that may be a gap in terms of oversight. And I should also mention that medications administered in hospitals are generally administered on an emergent basis and are not reviewed by the infrastructure of county behavioral health departments until after the fact that they have been administered. In Los Angeles County, where this matter is taken very, very seriously, we review approximately 12,000 JB 220 forms on an annual basis, and thereby have developed an infrastructure for this review process that includes a full-time pharmacist and a full-time child and adolescent psychiatrist to assist the approximately 25 juvenile courts. If there are concerns about the proposed medication, then the inquiry ensues into a more extensive review, which may include direct communication with the prescriber, a visit to the child's home, and a review of medical records if necessary.
And Doctor, I don't mean to cut you off at all. I'm just going to have you take another 2 minutes just because I want to make sure we get to questions as well, sir. I apologize.
In addition, the county has developed some clinical parameters that relate to restriction of the use of psychotropic agents among the foster care population, with the highest restrictions reserved for the very young age group. Also, the County Department of Mental Health has developed clinical parameters around dosaging and any other relevant issues, medical issues, for the use of these medications in children. These parameters are updated on a quarterly basis in collaboration with local academicians, pediatricians, pharmacists, and community prescribers. The state expert panel has recommended to DHCS to adopt the Los Angeles County Department of Mental Health parameters. In summary, the association deems it essential to collaborate with all the human service systems in order to best serve these children. And so the association is committed to working with all the folks here on this panel to resolve the remaining challenges. Thank you.